Okay, it's time. It's time. Thank you for everybody's coming. Good morning and good evening. I am P.Y. Cho and my colleague, Dr. Junior, too. We both will moderate this webinar together and welcome to ICC webinar today. We are so happy to have Professor Roberto Flores here to instruct our members of ICC with his great knowledge and experience. Actually, this is one and the first the topic of the series, and that is the pre-congress of the Chang Forum 2024. Professor Flores now is currently Joseph the McCarthy Associate Professor of the Reconstructive Plastic Surgery and the Hanjong Vice Department of Plastic Surgery at NYU Grossman School of Medicine. And he is also the director of the Plastic Surgery Craniofacial Fellowship Program and the director of the Cleft and Palate Program too. Professor Flores earned his MD from NYU at 2001 and being the residency in the NYU Lagoon Medical Center Teach Hospital 2007 and complete his fellowship at NYU Medical Center Head and Neck Surgery 2008. Professor Flores' practice is almost exclusively dedicated to aesthetic and reconstructive surgery of the face, both in children and adults, cleft lip and palate, craniosynostosis, rare birth defect of the face, rhinoplasty, facial trauma, nasal reconstruction, burn surgery, pollen syndrome, and the secondary reconstruction of the face. As the director of Cleft Lip and Palate at NY Lagoon Medical Center, he leads a multidisciplinary teams of specialists within one of the most comprehensive units in the States. His treatment philosophy blends the principles and techniques of both aesthetic and reconstructive surgery in all his patients to provide and optimize and customize the surgical plan. Academically, Professor Flores is a very productive scholar and contributes quite a lot to the craniofacial field, including the paper publications and the textbook. Besides, he very often been invited to give the presentation internationally. A large story about Professor Flores to be well addressed is here. Today, we invite two very good friends with the Professor Flores to come be as the panelist. One is Dr. Raymond Chase from Seattle Children's, United States, and Dr. Renato Freitas from the University Federal do Paraná, Brazil. So can wait to learn from Professor Flores. The topic is the NYU protocol for primary reconstruction of the unilateral and the bilateral cleft. And the video is ready. Okay, give a second.
Hello, this is Dr. Roberto Flores, Joseph G. McCarthy, Associate Professor of Reconstructive Plastic Surgery and Director of Cleft Lip and Palate at the NYU Hans-Georg Gries Department of Plastic Surgery at NYU Langone Health. I am also a member of the Smile Train Global Medical Advisory Board. I'd like to thank Dr. Peng Yun Choi for this invitation, as well as the Chang Hospital Plastic Surgery Group. My talk today is entitled NYU Protocol for Unilateral and Bilateral Cleft Lip Repair. The NYU Department of Plastic Surgery has a long history in cleft and craniofacial reconstruction. Pictured here are our three previous leaders, Dr. McCarthy, all the way on your left. In the middle is Dr. Court Cutting, who's been an incredible mentor to me and was a previous director of the cleft unit. And the third person here, who's a critical figure as well, is Dr. Barry Grayson, who developed many protocols that are used and still are being used in our unit today. But time evolves just like in all places, and this is our leadership team now. In the upper left-hand corner is Dr. Eduardo Rodriguez. He's a face transplant surgeon, microsurgeon, maxillofacial surgeon, and plastic surgeon. The gentleman to his right is Dr. David Staffenberg, one of my partners and a really talented craniofacial surgeon who trained under Dr. Kawamoto. I'm, of course, pictured in the lower right, and a very critical figure for our group on the bottom right is Dr. Pradeep Shetye, who was a big student of Dr. Grayson and has been really the central part of a lot of our more challenging cleft and craniofacial reconstructions. So for us, the evolution is the only constant, and the bar is constantly raised in terms of our outcomes and what we expect of ourselves. And the long-term follow-up, which we're more capable of doing now, really reveals new challenges, new techniques develop, and they're actually better forms of assessment now. And that really informs some of our own decision making. And the NYU protocol, continues to evolve. Even what I'm going to present to you today is in evolution, and I will talk to you a little about that towards the end of the talk. So the lecture goals today is really going to be a focused presentation on our protocol. Because of time limits, I can't go through all parts of it, but I can go over some critical parts that we're known for. One is the use of pre-surgical infant orthopedics in the form of nasoalveolar molding, our technique for infant cleft lip and nose repair, our implementation of gingiva periosteoplasty, which I do not think has had enough attention, and then also the future directions from everything that we've learned over the decades of care. Where are our new areas of change? And I think this is very important for the future. So the NYU treatment philosophy, in short, it's a comprehensive restoration of form and function. And I think many of us would agree that this is that this is a standard statement for cleft centers. However, one thing we actually believe very strongly is in operating less. And a lot of our research has been kind of indirectly focused on those outcomes. First of all, we do all single stage procedures. I really do not do lip adhesions. I do single stage cleft palate repairs. And I think limiting anesthetic exposure is very important for patients. And a lot of our protocols have resulted in fewer revisions. We've had numerous publications on our revision rate, whether it be on the lip or the nose. And again, not exposing patients to excessive anesthetic exposure, having a result in which their sense of self is one that feels restorative and the patient does not feel compelled to seek further surgery. And we've also avoided some procedures completely to a degree, such as alveolar bone graft. However, these are conflicting goals. You want to get the best result possible, but actually operate less. And this is why it's hard. But these are conflicting goals, but we do believe they are achievable. And in part of this talk, I will try to convince you that this is. And of course, one of the foundational procedures that we're known for and that we implement is nasoalveolar molding. I'm not going to go really deep into what it is because many of us here know it, but I think this picture really brings to light what this form of pre-surgical infant orthopedics does. When you see it's the same patient before or after a nasoalveolar molding surgery. On the left side is a child with a rather wide and severe form of a unilateral cleft lip deformity. And now on the right side after nasoalveolar molding, we see that the alveolar segments are aligned, the alveolar bases are nearly symmetric, and the alveolar gap is enclosed in a way where I can perform a gingiva periosteoplasty, which we know in about 60% of patients we can avoid an alveolar bone graft. And most critically, the nose. With a nose that looks like the patient on the right side, one could guess and predict that this patient will be much less inclined to need revisional surgery. The likelihood, if they had only one procedure, that they would look actually pretty decent at the time of facial maturity is much more significant, in my opinion, than the patient on the left side who hasn't undergone any molding at all prior to the surgery. But in short, nasoalveolar molding will lengthen the columella. It'll medialize the alar base. It medializes the lateral lip, expands nasal lining, shapes the nasal cartilage, and repositions the alveolus. However, the complement of that in our practice and in our protocol is gingival periosteoplasty. And what is that? That is a boneless bone graft that's created by forming a periosteal sleeve between the alveolar segments. It's performed in our unit during cleft lip repair. Some people do it during cleft palate repair. It requires highly skilled pre-surgical infant orthopedics, but it's also technically challenging. I would say if you look at the outcomes, it's quite varied, and in certain centers, they've shown great results, and there's some other centers actually quite poor results. So this is a highly technical procedure. However, for those centers who do this a lot and do this well, we are able to avoid secondary alveolar bone graft in many of our patients. Another critical part of our protocol is our cleft lip repair, and the molar cutting repair is the one that we and I prefer. It is probably the closest to a straight line or subunit approach. I'll go into what, the use of the terminology a bit later. But this is something that is a big part of our treatment protocol. And when you look at the cleft lip repairs, there are actually three major repairs with some variants that most of the world uses. One is the rotation advancement repair by Millard. The other one is the Fisher repair. I don't like calling it the subunit approach because it is not a subunit approach. It's there's a Z in it. There's a triangular flap. There's no subunit and triangular flap that breaks a subunit line. So that doesn't make any sense to me. It's a Fisher repair, and it's a very good repair. And then finally, there is the cutting molar approach, which is the one that we use. So what are differences between these? Well, there are many, but I would say one of the big differences is really about the back cut and its implications, right? So we have a back cut here at the top of the upper lip in a patient with who's undergoing a Millard repair. The back cut towards the bottom of the lip, which actually makes it the most easy to control. Like if you want to level or correct the upward rotation of Cupid's bow, and your back cut is very close to Cupid's bow, I would say the Fisher repair is the most reliable one in terms of leveling the Cupid's bow, right? Because you're much closer to the area that you're trying to change. And then you look at the molar repair, and the back cut is actually on the columella. So you're actually farthest away from that one aspect of the cleft lip repair, which is leveling the Cupid's bow. So actually, in certain ways, it's the hardest one. Okay, I think it's the hardest one to implement and to learn, and that's maybe why some people don't like to use it. The other part is that because you have this scar in the nose, you are actually preserving the subunit border of the upper lip, and that's one of the reasons why I prefer this technique. There are other aspects that I think haven't been addressed as much or haven't been showcased in terms of the advantages of the extended molar, the cutting molar. So here we have the drawing of the molar back cut with the border between the C flap and the M flap. And what you see is what this creates is a Z-plasty of sorts, and unbalanced Z-plasty, but a Z-plasty anyway. So as part of the Z-plasty, you have two aspects that are moving. One is that you have the Cupid's bow, which is upturned, and now through the formation of the Z-plasty, it can move down. You have one part that's moving down and one part that's moving up, right? So then this is the mechanism that the Cupid's bow is leveled, and you see this here in these excellent drawings by David Lowe, and this part is obvious. What are some other parts that may not be as obvious? Well, one thing is that this back cut here that's now at the columella, well, this gives us access, a medial access to the nasal tip. And you can see this here as part of our reconstruction. We are actually doing a dissection over the lower and upper lateral cartilages, and this gives us medial access to a minimally invasive means of getting into the nose and reshaping and repositioning the lower lateral cartilage. So the position of the location of the back cut itself in the extended molar is advantageous to primary rhinoplasty. The other part is, remember, this is a Z-plasty, right? So the lip goes down and this limb goes up. And by incorporating a hemimembranous septum incision, and I'll go into this and I'll show a video a bit later in the talk, we can elevate the depressed lower lateral cartilage and affix it into a new position. And that really helps and is quite advantageous for primary rhinoplasty. So all these in combination are advantages of the molar repair. And one final one actually is the fact that you have this back cut here means that if you think about any back cut, it creates an additional scar, right? Either in the fissure repair, it's at the lower lip, in the molar repair, it's the upper part of the upper lip, and in the molar, it's in the nose, at the base of the columella. However, let's talk about scar quality. We published a report in looking at scar quality of the molar repair on the base of the nose compared to the lip. And we looked at all patients whether they underwent a molar or a non-molar repair. And what we found is the scar quality, a vertical scar on the nose, is actually much better, statistically better, than any scar quality that you have on the lip. And in fact, I do nasal revisions at times on my patients. I do lip revisions at times for patients. In the hundreds of surgeries I've done with the molar repair, I've yet to do a scar revision on the nose because it's something that is rarely seen, and I'll show you many pictures of that later in this talk. The other part about the fissure repair, which for me as someone who embraces the cutting molar repair, is a certain kind of math, which is the average height of the upper lip is about at 3 months of age is about 10 millimeters. So I usually perform cleft lip repair at 3 months of age. If you measure the length of the upper lip, the skin part of the upper lip, it's about 10 millimeters. Well, the average height of the fissure triangular flap is about 2 millimeters. I think in maybe skilled people, they can make it 1.5 millimeters. I don't think it's realistic to make it 1 millimeter, but let's say in the average cleft surgeon is about 2 millimeters. Well, that's about 20% of the upper lip that's taking up a triangular flap, which I find it would be less aesthetic than having a straight line. And then I asked myself, well, how are revisions made? If you have a triangular flap, and sometimes I do revisions on my own patients. If I have a straight line, I just do a straight line and that's it. But if you have a triangle in there, it's unclear to me how these revisions are made. And then what happens to the philtral shield? This is a picture of a colleague of mine. He's a very good friend. He's a very talented cleft surgeon. One of his publications showing actually not aesthetic results of the fissure repair, but some other endpoints. But here's a patient 5 years, a very good result. Nose looks great. The lip looks leveled. However, I do see this scar, right? I would much rather have a straight line scar, but this is, and there's a philtrum. So you see the triangles going actually pretty close to the midline of the philtrum, and this is about 20% of the upper lip. So these are the subtle details that I look at when I'm trying to choose the cleft repair that I want to implement on my patients. So moving on to primary rhinoplasty. This is something that we really perform in all, if not nearly all, our patients. Just undergoing pre-surgical infant orthopedics with nasal molding, whether it be a NAM or another procedure, is not rhinoplasty. The nose will relapse if you don't do anything. So the college repositioning is critical to success, and we need to overcompensate the position of the lower lateral college. I'm going to move my face here. This is something that has been shown very well by the Chang Gung group, and this is something that we definitely embrace. And the nose needs to stand up on its own. We do not put primary cartilage grafts as they do in Taiwan, but this is what I want to see at the end of the table, at the end of the day, at the end of the case, excuse me, on the table, because I know the lower lateral cartilage will go down a little bit. And in fact, ideally, what I like to see is the nose to stay up even a couple weeks after the surgery. And this is what I want to see. This is the patients who I feel like they're really going to get a very good nasal result. And I do 2 different rhinoplasty techniques depending on whether or not the patient has undergone NAM, or they haven't undergone nasoalveolar molding. So here's a demonstration of the hemimembranous septum incision that is done. These videos are available through a simulator that's available through SmileTrain. You could go to cleftsum.com. There's no money that you need to put into it, or you can actually get a phone app. But you see we are doing a hemimembranous septum incision. This goes all the way up to the septal angle. And then through the apex of the molar incision, I'm just simply doing a blunt dissection between the medial crura. Okay. And once I've done that, I can do a subcutaneous dissection over the lower and upper lateral cartilages. And you see how that the apex of the molar back cut on the columella really facilitates my entry into the nose. It's a subcutaneous dissection, and I am dissecting the lower lateral cartilage in preparation for repositioning. And again, now taking advantage of that Z-plasty, I can now, and now with the hemimembranous septum incision, I can elevate the depressed lower lateral cartilage into an overcorrected position superiorly. And now I'm simply just putting two layers of stitches. One are a group of horizontal mattress sutures in the medial crura. And what I need to do is hold the lower lateral cartilage in a supercorrected position while I am affixing the medial crura into a new position to each other. And this will also form the columella. And you see the vertical scar that will result on the columella itself. The next set of stitches is very important. This actually goes through the septal cartilage, which is a very fixed point, and now I'm going through the medial crura in my return suture. And what that will do is that will fix the vertical position of the depressed lower lateral cartilage and the medial crura to the septum itself, and that really helps keep the position of the nose in a stable position at the end of the case. These are long-lasting absorbable sutures, PDS, and you see at the end of this portion of the procedure, we have a nice lengthening of the columella. Next, the lateral aspect of the lower lateral cartilage is still depressed, and we need to put in some sutures to elevate this. And this is a very difficult suture to put in, but basically it's an internalized kind of retention suture. So what I'm doing is going from the lower lateral cartilage subcutaneously to the upper lateral cartilage in the opposite nostril, then going through the upper lateral cartilage again, and then through the upper lateral cartilage back as an oblique horizontal mattress that goes nostril to nostril. And you see here at the end of the case, I like to have a little bit of a supercorrected position of the nostril. And then finally, in certain cases, I'm actually doing less and less of this now, but in certain patients, I do do this. It's a vestibular web obliterating suture. I think many of us use this. It's a buried horizontal mattress suture, and that can be helpful. I wouldn't say it's 100% effective, but that can help with the excess nostril skin on the lateral aspect of the nostril rim. In patients who have a rather severe cleft nasal deformity and do not undergo nasoalveolar molding, we use a similar technique, but in this case, we're incorporating a nostril rim incision. So again, here's a very good view of the membranous septum here on the cleft side. So we're only making a hemimembranous septum incision. We're only making the membranous septum incision on the cleft side behind the medial crura and anterior to the septal cartilage. And again, here we have the medial approach that we're going through the apex of the molar back cut. And once we've done that, I will do a nostril rim incision. And I know with some people, doing a nostril rim incision is good. It's not good. It's bad. You can have scarring. I think that just like many things in cleft and craniofacial surgery, certain things require more skill, some require maybe lower skill. I think if you're going to take a knife inside the nose in an infant, it's higher skill. And certainly if there is an opportunity to perform iatrogenic injury, I know that some surgeons think this is a very, very bad idea. I think that actually it's a great idea if you know what you're doing. One could do for us who are craniofacial surgeons, one could do a monoblock and kill a child, or one could do a monoblock and change their life, for the better. So this is something where it's a higher skill type of procedure, but this is something that's common in our hands. And basically we're connecting these two pockets, one through the medial crura, and then the other pocket is through the nostril rim incision. And it's very important to make it inside the nostril rim. Obviously, you don't want to go onto the skin of the tip of the nose. And then similar to what I showed previously, we have the Ragnar retractor elevating the depressed lower lateral cartilage into a supercorrected position, putting in several horizontal mattress sutures through using a long-lasting absorbable suture, and then also putting in another layer to affix the medial crura to the septal cartilage. Once this is done, we still have to perform a a repositioning of the lower lateral cartilages more laterally. So you see here, we really want to bring that superiorly and medially right there. So I'm sighting where I want to put the stitch. And it's more laterally than you may think at first. And in this case, I'm simply going through the intranasal portion, going out the my nostril rim incision. And in this case, I'm staying ipsilateral. And right there, you see I'm going right through the upper lateral cartilage. This is very important. The upper lateral cartilage is actually a pretty fixed unit. So if you're able to get the suture through there, you will have a nice grip and it will move up. If you put a stitch in the upper lateral cartilage, you can lift the kid's face off the table. So this is an oblique horizontal mattress suture with a superior and medial vector, again with a long-lasting absorbable suture. I will later put a similar suture, nostril to nostril, oblique horizontal mattress. And then after the the lip is closed, there's still, in certain cases, a kind of an excess of skin overhanging. Now, you could just suture it up, but in cases where the cleft nasal deformity is actually pretty bad, I think that it's a good idea to very, very carefully, and I would stress carefully, remove the small excess of skin. If you cut too much, and it's very easy to do this, you'll create a very, very bad deformity on a child that's very difficult to correct. So you have to be quite careful and very exact here. The safer thing to do actually is to not resect any skin at all, to be honest with you. But I think that if you're careful, then you should be fine. Now, the closure is with a 7/0 vicryl suture, and again, I think if you take good care of your patients postoperatively and you have good technique, the risk of iatrogenic damage is actually quite low. All these patients underwent one procedure. This is what they look like at the age of mixed dentition. So this is a 8 to 10 year follow-up. One surgery with NAM. Many of these kids underwent gingival periosteoplasty as well. And what we like to see, and all these patients, you're going to see they have a pretty significant nasal deformity preoperatively. And this is what I like to see. These kids, the likelihood that they will need, let's say, a touch-up surgery. This is actually this is a pretty bad nasal deformity. The nostril rim is inferior to the nostril floor of the other side. This is again one surgery, no touch-ups at all, no secondary rhinoplasty, and these kids look like any kid that you might see in a classroom, in a playground. Again, these are really more of the more severe non-syndromic patients that you would see. And just to show what is possible. This person, you see, they have a neonatal tooth, pretty severe cleft nasal deformity. Again, all these have been one surgery at 3 months of age. Asian child, I put Botox on the lip. Thank you, Chang for your excellent prospective randomized trial. I use this in all my Asian patients, actually. And again, these are results that I feel like, can I get this without nasoalveolar molding? I think I can, but can I get it consistently? I don't think I can with one surgery. And my goal is really to get the best results, most lasting results possible through the minimal amount of surgery. Now, one of the criticisms of the molar repair is that it is not as effective as other procedures like the rotation advancement or the fissure repair in leveling the cupid's bow. And that is correct. I do believe that. I think those studies, the studies that I've read about that are true. And it's because, again, it's a harder repair. You are putting the back cut far this away from the area you're trying to change. So here's a child in which this happened, and I see that. That's fine, but honestly, that's an easy fix, right? That is a simple diamond excision that I can do during alveolar bone grafting or when they're older in the office as a child. So yes, these are some limitations. Here's another child in which I didn't get it down quite as well as I wanted to, and you have that kind of creep. If I put a triangle right there, that the likelihood that would happen is actually is lower. This is the truth. However, I would rather have a straight line scar right here and just do a very simple wedge excision in the times in which I am not performing at my best. And that triangle excision can get, you can adjust the length depending on how far up it goes. So how does NAM affect facial growth? This has been kind of this question that has been posed to our unit several times. And actually, it's a complicated question to answer because there's so many things that affect facial growth in cleft. Pre-surgical infant orthopedics, the severity of cleft, the surgical techniques that are used during the cleft lip repair. Do you do primary bone graft? Do you do GPP? What kind of lip repair do you use? What kind of palate repair do you do? Are you using a volar flap? Or you're not using a volar flap? The amount of revision surgery and even orthodontics. So I think it's a very difficult question to answer, particularly in a prospective randomized trial, which I know a lot of people are into. I think it's actually a bad idea that will not give you any information. I think you have to do much more controlled studies to really answer this. But in general, these are many of the issues that we have to contend with when we're talking about facial growth. But I would say first, let's think logically. When we have a child with a wide unilateral cleft, we would like to go from here to here. And in nasoalveolar molding, we're able to do that through skilled orthodontics in about 10 weeks. Okay, how else is what are other ways in which the alveolar segments are molded into place? Well, the most common one is just doing a lip repair or a lip adhesion, right? Many of us have done this, and we know that if we don't do any molding and we do a lip repair or a lip adhesion, the alveolar segments will really come together really in about 1 or 2 weeks, right? It's just because the muscle's there. So that's a more rapid form of manipulating the alveolar segment. So what about a Latham device? Well, that one is a more active form of pre-surgical infant orthopedics, and in those cases, you are repositioning segments in 3 weeks. Okay, and what about other molding therapies, taping, Dynacleft, what have you? Well, those take about 10 weeks in a patient with a unilateral cleft. So if NAM takes 10 weeks, why is everyone so worried about how it can damage facial growth? That part logically makes no sense to me. But we can go from, and I will get into data as well. And then the other aspect, again, is GPP. Why do it? Well, it is a controversial procedure. I think some people have embraced it. Some people have used it and then stopped using it. The results are mixed, as I mentioned before, and the potential for harm is significant. So is it really worth it? It hasn't been previously discussed in depth by our unit because years ago, NAM was considered a very controversial procedure. The discussions weren't discussions, they were arguments, they were very heated. I remember being there as a junior faculty and as a trainee. And so if you're having that kind of discussion about nasoalveolar molding, really can't have any kind of cogent discussion about GPP. But let's be honest, there can be real concern. What if it doesn't work? Are you harming facial growth? What do you do if you don't have access to NAM or a skilled orthodontist? Can you do gingiva periosteoplasty? And how does one safely perform this procedure? How do I indicate patients for this procedure or say this person isn't a good candidate? And by the way, the results of bone growth, you won't know for about 7 to 8, 9 years. And the results of facial growth, you won't know until they're facially mature. So we understand the hesitancy. But we're going to start showing you some data. First of all, gingiva periosteoplasty is not well understood, partially because not a lot of people do it, but in the different forms. The first form was described by Dr. Skoog, and it was a boneless bone graft. The problem in terms of the way he did it is they didn't have pre-surgical infant orthopedics. The alveolar segments were widely separated, and he did several procedures and wide dissection of the mucoperiosteum from the alveolar segments, so he had poor facial. The second iteration was actually through Dr. Ralph Millard in conjunction with a lip adhesion and a Latham device. And that required less dissection, but there was still a significant amount of dissection. And Samuel Berkowitz, his former orthodontist, felt that there was facial growth inhibition or damage due to the Latham device. So then those protocols were eventually not abandoned, but I think it didn't really take off. Next iteration really was through Cutting and Grayson that implemented nasoalveolar molding using guiding orthopedics and precise apposition of the alveolar segments, which allowed for minimal dissection of the alveolar segments themselves. And there's been a well-described success, but people have been questioning and critical of facial growth. And let me just show diagrammatically what we mean by limited dissection. The subperiosteal dissection really is limited to the mesial and distal segments of the alveolus. We're not going labially, we're not going lingually, okay? So you just make these cuts really at the edges of the at the ends of the alveolar segments and creating a periosseal tunnel this way. You're not making any dissection here, here, or here. And in doing so, you're really limiting the creation of scar and in our mind, preserving facial growth. Now, gingiva periosteoplasty has a great success in advocacy internationally. In Seattle, with Richard Hopper, who's now in Austin. The lovely Castana Mehazzini, who is a president of the European Cleft and Craniofacial Society. We'll see you all in Milan later this month. Now the late and great Dr. Tony Wolf using this in Miami. Of course, New York, we've used this a lot. Marcos Colares in Brazil is a very big advocate and has a huge experience using gingiva periosteoplasty. And when he was at Chang, Philip Chen published many reports on this technique. Now, all of these units did show us some growth results and also some long-term results with about 58 to 92% avoiding bone graft, which is actually very important. I would note that they all have very strong orthodontic units. And I think it's very important to understand that it would be difficult to do something like this without having a very skilled orthodontic partner. And there has been some variations. We all actually do things a bit differently, I think. But let's go into some of the data. So one of the questions and concerns was that by doing this, you're harming, you can destroy the tooth buds, and in so doing so, harming facial growth. This is a study that was performed by Travis Gibson, one of our former orthodontic fellows who's now in Vancouver. And we looked at patients, almost 100 patients, half of which underwent GPP, half of which didn't. They all had a unilateral cleft. And in this case, we did a dental assessment. If we're harming the teeth, the growing teeth, we should see this when the teeth have erupted. So we did dental assessment and radiographs after their adult teeth have erupted. And we looked specifically at the cleft, lateral, and medial incisor. And we compared the rates of intact, malformed, absent, and multiple teeth in patients who underwent GPP or no GPP, in patients with unilateral cleft, and the rates were similar. So we felt that in experienced hands, you can preserve the dentition. Another question has been asked, so when do you perform GPP, when do you not perform GPP? Dr. Elçin Selnik, who is now chair of orthodontics at Akdeniz University in Antalya, Turkey, she was one of our research fellows several years ago, and she performed a study that looked into alveolar position that was more favorable or less favorable for successful GPP. We found that precise alveolar segment alignment, not only horizontally, but in the vertical plane, and that's something that some people have not really appreciated as much, and a 1 millimeter gap is the optimal alveolar position for alveolar bone graft. This is a long-term study that was published about 2 years ago in Plastic and Reconstructive Surgery. This won Paper of the Year award from the American Society of Maxillofacial Surgery, and this is a long-term outcome report on patients who underwent our cleft protocol, unilateral cleft to facial maturity. And in this case, we saw a 59% success with GPP. Only 10% of our patients underwent a lip or nose revision prior to facial maturity. Okay, so again, it's very important in terms of our protocol. So that means 90% of patients before facial maturity only had one surgery to lip and nose, right? So we want to do less surgery and have the patients feel restored and not feel they have to undergo revisions after revisions. 30% of our patients underwent orthodontic surgery. These are patients with a complete unilateral cleft of the palate. 20% of our patients, I'm proud of this, 20% of our patients underwent no revision, no ABG, and no orthodontic surgery. So these are patients who are Vo3 cleft palate, complete unilateral cleft lip, 20% of it. And this is through our protocols. And we have comparable facial growth to the Eurocleft Center. So Eurocleft is the largest repository of cephalometric data on patients with the unilateral cleft. And whether or not our patients had NAM or NAM with GPP, our facial growth was comparable. Here are the five Eurocleft centers. We chose Eurocleft Center E and D because they most similarly followed our protocols, and Center E did not do nasoalveolar molding, and Center D did not do gingival periosteoplasty. In truth, our data is consistent if you look at all the Eurocleft centers, but we thought that these were the better match. So you see that the SNA is comparable in patients with NAM versus no NAM between Eurocleft Center E and University, and in patients who undergone GPP between NYU and Center D, also similarly showing very good evidence, long-term supplementary to facial maturity, that we are preserving facial growth potential. However, that we have had kind of scathing people kind of coming after us, and this was I encourage you to read this very inappropriate article, letter to the editor by great guy, but just very angry. And God bless him, Samuel Berkowitz, who had something against NYU for a very long time, and he wrote this kind of scathing letter to the editor, which was quite inappropriate. Why hasn't Cutting and Grayson done a longitudinal study, et cetera, et cetera. But what I liked about it is it provided an opportunity for Dr. Shetze and I to actually give a response and say and show where he was confused in his thinking. But one of the things that I realized is, you know what, if you're so worried about, let's say, gingival periosteoplasty, the best way to control that is to look at patients who have an intact palate but a cleft of the alveolus, because I believe that the major detriment to facial growth is the palate, not the alveolar segment. And we ended up completing this study. It was just published actually last month in Plastic and Reconstructive Surgery by Jennifer Park, who's now one of our residents. And what we did was we looked at 4 patient cohorts. The first 2 cohorts are patients with cleft lip and alveolus only, palates intact, and they either did not undergo GPP or they underwent GPP. Then we had the other pair of patient, the other 2 patient groups had cleft lip and palate, both 3, and had GPP and no GPP. And in this case, we followed them to the age of mixed dentition, compared the facial growth parameters to each other, and then very importantly, we compared to patients with a cleft lip and alveolus with Bolton nomograms, which are kind of normally unaffected patients. Okay, so this is our data. It's published. You can see it now. If you look at within groups of the patients who've had cleft lip alveolus with or without GPP, the facial growth parameters are similar in terms of SNA. Cleft lip and palate with or without GPP, facial growth parameters similar to age of mixed dentition. Great, not surprising. Also not surprising is if you had a cleft lip and alveolus with no GPP and a cleft lip and palate and no GPP, your facial growth is worse if you had a cleft palate. Not surprising at all. And the same thing if you did that similar kind of comparison with patients who did have GPP. Of course, if you have a cleft palate, your facial growth parameter is going to be worse. What's most interesting to me is when we look at patients with cleft lip and alveolus with or without GPP, their facial growth parameters are comparable to Bolton nomograms. So what is the big deal about this, the GPP thing? Now, I understand we have to follow these patients to facial maturity, but we feel like this is actually quite strong evidence, the fact that if you do GPP in a skilled manner, we're not doing something so horrible to a patient. So the conclusion of this study that in patients with cleft lip and alveolus, application of GPP doesn't negatively affect maxillary growth. In patients with cleft lip and palate, GPP does not negatively affect facial growth. However, maxillary growth restriction appears to be more dependent on the presence of a cleft palate. Now, of course, these findings are limited to the age of mixed dentition. It takes a while to get a cohort of patients with cleft lip and alveolus only who had GPP and following them, and we will publish this eventually. Let's go a deeper dive into bilateral cleft lip. The timing of this, my time allotment will not allow me to go in great detail about our protocols, but I do want to talk specifically about our application of GPP in bilateral cleft lip, because again, this is something that I think is not well understood in terms of what we do and why we do it. So bilateral cleft lip, as you know, is much more challenging to correct. The mechanics of NAM are different. The anatomy is different. Facial growth outcomes may be different. That's why you need a separate study. However, GPP is also applied to different endpoints and has distinct application principles to this patient population. Importantly, though, one of our former fellows, who is now a faculty at Memorial Sloan Kettering, Dr. Danielle Rockland. She published a study in December of last year on our long-term treatment outcomes of facial maturity on patients who underwent bilateral cleft lip. And these patients were followed with a lateral cephalogram prior to orthodontic surgery, and we compared them with one of the largest other available reports on patients with a bilateral cleft lip, and this is from David in Australia. And in our case, in his cohort, a minority of patients underwent pre-surgical infant orthopedics, and none underwent gingiva periosteoplasty. So we felt this was a good group to compare to. We had 20 patients followed to facial maturity. Almost all of them underwent GPP. The average number of surgeries our patients underwent was 5, compared to the David, which was 8. So 5 surgeries, patients both were cleft palate, complete bilateral cleft lip. Our SNA values was comparable to David, maybe slightly worse, but comparable. They were statistically similar. Now, in terms of the post-surgical mechanics on patients with a premaxilla, and this was going to go into what the importance of GPP in my standpoint. It's an uncontrolled inferior posterior vector if you don't have molding, right? By reconstructing the orbicularis oris, you're putting the orbicularis oris sling around the premaxilla, which is outwardly rotated. And then you have a clockwise rotation of the premaxilla inferiorly and posteriorly, and it pretty much lands where it lands. It just rotates down and posteriorly. And in patients with a wide bilateral cleft, it can be inferiorly displaced, right? It can go down and back, right? And so what am I talking about? Well, I'm talking about this. These are patients we're all familiar with. It's so difficult to treat these patients. You have this locked out premaxilla. You're not, because the premaxilla is so far out, you're not able to close the palate completely. And you may need to do a premaxillary setback. And these are situations in which, when we talk about burden of care, the burden of care for this patient is so much worse than a patient in which the alveolar segments are brought together. This is a study in which we looked at 23 patients who underwent our bilateral cleft lip protocol with NAM, with GPP at least on one side. We followed them to the age of mixed dentition, and we had a 0 incidence of locked out premaxilla or need for premaxillary setback. And the reason why is because we were able to anatomically align the alveolar segments with the premaxilla and connect them surgically. And that is a huge benefit to a patient with a bilateral cleft when you think about how complicated things can be when you have a locked out premaxilla, when you have a descent of the premaxilla. So with regard to the NYU experience with a unilateral cleft and GPP, to perform successful GPP, the alveolar segments need to be precisely aligned to a 1 millimeter gap with minimal vertical discrepancy. You need a skilled orthodontist, and using NAM, that's critical to the success. Secondary alveolar bone graft can be avoided in about 60% of the cases, and no additional dental loss or deformity is noted, no detriment to facial growth. However, this is highly technique dependent, both from the orthodontic side and from the surgical side. In patients with a bilateral cleft, the use of GPP is even more important in my mind than in patients in the unilateral cleft. Here we have a patient who had bilateral GPP. We have good bone on one side, not as good in the other side. They'll need a bone graft, but I don't consider this a non-success because the alveolar arch has been restored. So in the unilateral cleft, the benefit is avoiding secondary alveolar bone graft. But what it really, the goal of GPP in a patient with a bilateral cleft is controlling the premaxilla with a bony anchor. That is critical. The bony dental health is better, improved, because the premaxilla now attached to the lesser segment can be loaded. You have less orthodontic work because you've avoided premaxillary lockout. You have better oral health because you're able to close the palate completely, and you won't have a fistula right behind the premaxilla. And a more predictable bone graft if needed. So this is even more critical in patients with a wide bilateral cleft, our most difficult patients. So conclusions with gingival periosteoplasty, GPP can avoid alveolar bone grafts. It's a technical procedure for the surgeon and the orthodontist. Anterior facial growth can be preserved, both in a patient with a unilateral and bilateral cleft. Dental development does not appear to be negatively affected in patients. And in patients with a bilateral cleft lip and palate, you can control the premaxilla. Mechanical loading of the central segment is possible. There's no need for premaxillary setback. You can avoid those, and no lockout of the premaxilla. That can be avoided. The patient and the palate can be completely closed in the first operation. Less surgery results in less scarring, and I think in better anterior facial growth potential. And what do I think is the real discussion with GPP? Well, who should have it and who shouldn't, right? Is the investment in pre-surgical infant orthopedics worth it? And I would say this is an important statement, which I haven't made yet. NAM, nasoalveolar molding, pre-surgical infant orthopedics, is not for everyone, and it's not should be used in all areas. It's not feasible in many areas, and we realize that. These are the protocols that we implement with our practice that we believe in, but the whole idea that it should be implemented all over the world in every unit doesn't make sense to me. But is the investment in pre-surgical infant orthopedics worth it? That's a discussion each unit should have. In patients with unilateral cleft, is the use of GPP a convenience for those who have greater access of care? I think the answer is possibly yes. In patients with bilateral cleft, is control of the premaxilla and potential price worth of lack of control of the premaxilla? I would rather control the premaxilla than not control the premaxilla. I think that's the most difficult part of bilateral cleft lip repair, if you really think about it. And in the setting of care, high versus low limited resources, this obviously affects the discussion. So returning to the NYU treatment philosophy, comprehensive restoration of form and function, we strive to operate less, all single stage procedures, fewer revisions, we avoid some procedures completely, and we do, in my mind, preserve facial growth potential with our protocols. And these are conflicting goals, but they are achievable. With the last few minutes, I want to briefly give you a teaser on where we are going now in the future. One of the limitations of NAM is a burden of care. We know this. We've just published a study looking at our own burden of care, the number of visits required. If you have a patient with unilateral cleft, if you come to NYU, you require an average of 13.5 visits. And a bilateral cleft, 18.6 weekly visits. That's a lot, right? If you live far, that's a lot. If you're a single parent, that's a lot. If you have two working parents, that's a lot. And by the way, you require highly skilled orthodontics. And this has resulted in some limitation of people accepting this as something viable or reasonable for them. And we understand that. So we've gone to our next iteration, and Dr. Pradeep Shetty, orthodontist, has developed a new device. For completely full disclosure, I have no IP, I have no investment in this. I make no money. No money comes to our unit from this. This is all Dr. Shetty's work. But I've been using this for now several years, which is a pre-surgical lip and alveolus nose approximation. He calls it plana. And basically, it's an innovation of pre-surgical infant orthopedics. It requires no adjustments. You have 3 devices that you just put in that are prefabricated. So prefabricated devices, it's simple to implement. There's no impression. There's no adjustments. Fewer visits. I'll go over what that means. It is better tolerated by patients. And it reverses the lip, nasal, and alveolar deformity. Similar, very similar, I would say equal to NAM. So here's a recent patient of mine, complete unilateral cleft lip, the usual things that we see on our more affected patients. Here's a patient after this new form of pre-surgical infant orthopedics. This is what I like to see prior to the surgery. And this is the child after. You see the slight overcorrection that I like to see, right? This is what I want to see in my patients a couple weeks after surgery. So we went from here to here. Normally, it's 13.5 visits for NAM. We did this in 4. Okay, that molding was done in 4 visits. Here's a patient with a bilateral cleft. Asymmetric. We have to align the alveolar segments, right? We did this. This is what I like to see prior to bilateral cleft lip repair. And I did a GPP on the right side. This is a child afterwards. Normally, this takes 18.6 visits through our protocol. We did this at 5. Now, I don't have the time to talk about this in greater depth. We are going to talk about this a little bit during the Euroclef meeting, and I hope to, at the meeting Kyoto in about a year and a half, we hope to give you some data-driven analysis of this work. I thank you for your time and your attention, and I am happy to answer your questions.
All right. Thank you so much, Professor Flores, for that amazing talk. And also congratulations on the tremendous results. So at this time, I'd like to invite the panelists for some comments. So the first panelist that I'd like to invite is Professor Raymond Che. So Raymond, the floor is yours.
Roberto, that was a tour. That's a lot of topics to cover, a lot of data to cover, a lot of things to think about. So congratulations on putting it together and showing us kind of your world, your thinking, what you know, what's helped you along the way, and kind of where you're going. So. I have a few questions, and you know, I think with all of the material that you've presented, it certainly does bring a lot of good insight, and it makes me think about things. And I guess maybe starting on, I guess, three questions maybe. The first is, and I'll ask each one at a time just because I think there can be some discussion around each. The first is, I think you kind of addressed a lot of it as you were talking, and you know, NAM is difficult, NAM is hard, and you pointed that out, and for families, it's a lot of burden. And I guess we showed the outcomes at 5 years of age after surgery were different, but they weren't tremendously different as far as the nose appearance goes. And so it's helpful, but it's not critical to the end result. I love the fact that you've gone to an alternative that may maybe involve a lot less burden. And one thing that I've seen is Dynacleft. It's another version of molding, and I wonder what your thoughts on that are, relative to NAM, relative to the other molding device that you're using, and how that may fit in with everything that we do. It's maybe an evolution of what we do and how we do things, and if we can make things easier for families, then it is a better thing.
Yeah, thank you, Ray. And you know, I've always respected your intellectual process. You know, you see it in your writing and you see it in your presentation. So I'm very happy that you're one of the discussants. I think in terms of, let's say you say Dynacleft versus NAM versus the Plana technique that Dr. Chette's developed, I think NAM is, in my opinion, a very effective device, but it takes a highly skilled orthodontist and a lot of visits and a lot of equipment and such things. The advantage of the Dynacleft is that it's not costly and it's simpler to implement. I don't think it's as effective, but I think that if you get someone who really gets skilled at doing it, and I think Daniela Tanagawa at Sao Paulo is a very good example of someone who is really on her own, and she is not an orthodontist, kind of implemented this, and I've seen her results, and they're quite impressive. So I think Dynacleft versus NAM, you still require a higher skill level. Maybe I would say NAM is the highest skill level to do it correctly. Dynacleft is still high, but a little less. And then this Plana device, a Plana technique, requires the least amount of skill and the least amount of visits, and that's the advantage when you want to compare the three.
And how do you think Dynacleft and Plana will change your ability to do GPP? I think of NAM as a very highly controlled way of molding, whereas Dynacleft, you're using tape. It's a little less controlled. And Plana, I assume that there's some taping on the lip as well to mold the alveolus and the maxillary segments. What are your thoughts on that?
We don't have that answer yet. I would say that I'm still doing GPP, both on the patients with the unilateral and bilateral cleft using the Plana technique. But in terms of the precision, I think the only way to answer that in an honorable way is to really look at our data, look at our photos, and look at our operative reports. So I would say preliminarily, it's comparable, but we, our unit, we're very data driven. We publish a lot. We really are numbers driven regarding our recommendations, just like you are, just like Chang is. So I would only say that preliminarily at this point.
Sure. I guess the second question was with respect to proceeding with GPP. Obviously there's concerns, and you've shown this morning that you can pull it off in a safe way, and you can be effective with it. What would you say? What would you advise for folks who are considering GPP as far as deciding whether or not to proceed with it, and what they need to have in place to go ahead with it? There are some centers that are well resourced. There are other centers that have more limited resources. What do you think are the tipping points in terms of actually pulling off GPP in a safe way?
When I was a junior attending, I wanted to learn. I was doing Dr. Mulligan's nasal repair for bilateral cleft, but I wasn't doing it well. So what I did was I visited him and I observed him, and we spoke at length about bilateral cleft. And it took, in that relatively short period of time of my visit, it was a couple days, my foundation was elevated, and from there I could grow even more. So I think if you're going to do a procedure like this, you should visit a unit that does this a lot. And there are different techniques. There are different ways people do it. The units that I listed, many of them are different in terms of the way we do it. Dr. Mazzini, they do it during the time of cleft palate repair. And it's just that they do a different protocol. They are very successful. They actually have the greatest success with GPP in terms of bone growth out of any of the units. They have found in their studies that there is a detriment to facial growth, but that's through their protocols, right? So I think you have to, for GPP, I would say you should visit someone and see what they're doing, because it's very technique dependent. I think you really do need a very good orthodontist to partner with, because you do need those alveolar segments aligned.
Kind of on the same vein, as far as rhinoplasty goes, we're friends, we're good buddies, we have very different approaches. We have differences in how we do things, the lip repair as well, I can love Roberto Flores, even though he does something different from me. As far as rhinoplasty goes, my experience doing definitive rhinoplasty, for example, where sometimes there's been previous dissection, primary, it's a secondary rhinoplasty by definition, or tertiary rhinoplasty if a child's undergone a intermediate rhinoplasty, and they can be difficult, they can be tricky. Sometimes I'll run into lower lateral cartilages that have been transected, for example. I'll run into scar that makes it really hard to shape the nose and really hard to get what I'm hoping for, even though the starting point may not be as severe as a child who hasn't had a primary rhinoplasty. And so I think, if you're engaging in primary rhinoplasty, you need to be careful about it. You need to be thoughtful about it, and you need to do a nice job of it to get us kind of that one step forward. And I guess when kind of it gets to the same question is, if you were to suggest to surgeons what they need to think about, what they need to do, or how they need to feel about what they do before they engage in primary rhinoplasty, in terms of incisions or in terms of dissection, what is it that what a surgeon should have at their at their disposal to be able to pull it off in a way that's well and in a way that effectively gets them one step further. Because the last thing you want to do is have somebody undergo a primary rhinoplasty, not have a good result, and then have a more difficult secondary or tertiary procedure down the road.
Yeah. And everything that you're saying, we've all experienced this. So that is the concern. And I think that the two most difficult sequelae to deal with in a patient with unilateral cleft is, one is a very difficult fistula, and two is a overoperated nose, right? Those are the two hardest things. I would say, one, I have operated on many of both of Dr. Mulliken and Dr. Cutting's patients at facial maturity. Those are highly skilled surgeons who do a fairly comprehensive primary rhinoplasty. And I really haven't seen with their techniques, and they do something a little different, problems. Like Dr. Mulliken does very standardly do an intranasal incision, and I have yet to see bad scarring. Now, he is a master surgeon. And with Dr. Cutting's patients, he has a very low revision rate. You see this, our protocol's low revision rate. So I think it's the over-operating on the nose, number one. And then two, the way you do that primary rhinoplasty, I mean, it's all, for me, it's all blunt dissection. I don't take out any fat. And I tried not to, I'm very respectful of the cartilages, but I would agree. This is it's a higher skill, procedure. And I think you have to understand you're operating on an infant, on a 3-month-old in my case. And you do have that potential for harm. I think doing many touch-ups, which is part of other units protocols, I'm very much not in agreement with that. I think that the less you touch nose, the better. So if you're going to do something, do the most comprehensive change you can with a minimal amount of surgical manipulation. That's a balance. That's why it's hard. I think any form of pre-surgical infant orthopedics that effectively changes the nose will help that cause, right? It will position the nose in a better shape, so that you have to do less during your rhinoplasty, right? When I have good molding, I end up doing a more conservative rhinoplasty. I have 2 different rhinoplasties depending on whether I have molding or not. And the one that I use when the patient's molded is less invasive, right? I'm not making an intranasal incision. I'm not creating more scars, right? So if you can mold the nose better, you're going to do less surgery later.
Thanks, Roberto. Like I said, a real tour de force, and I don't want to take up all the time and the questions, and want to make sure that I leave some to Renato, so that he can ask what's on his mind.
Thank you so much, Ray, for your comments. And so next, I'd like to invite Professor Freitas.
Oh, morning, everybody. Roberto, it was a great lecture, and we present a great experience also of an NIU, and I learned a lot. I saw some lectures 3 months ago, and I always learning a lot when I saw lectures like that. I'd like to focus about the nose, that we have a different approach for unilateral and bilateral clefts, and also we do not have use NAN or other device pre-op. So, but in our experience, we don't have a lot of also revision that you show. If I'm not wrong, you present that you have 20% of no revisions and the end of and 10% before the adult time. Yeah.
Yeah.
And, but when I saw this case, I'd like to ask you the first question for you about septal deviation, even using NAN and your approach. I'd like to know about septal deviation and what we're going to do for the septum in your case.
Thank you. So earlier in my practice, I didn't do too much to the septum. And then over time, I saw what some people were doing to correct the position of the anterior septum. And now I am doing that more. And some of my patients that I showed that I did about 8 to 10 years ago, you see in some of them there's a little bit of septum kind of out there, and that in my later patients you're going to see less of that. So I think doing an anterior septoplasty is important. One of the problems that I have with the way people are talking about it is that they're saying that, well, we're improving the airway, which I fundamentally do not agree. I think this is an aesthetic procedure. We've done studies of the nasal septal anatomy at the age of mixed dentition and at facial maturity. And as we know, patients with unilateral cleft can have a very deviated septum. And in fact, the area of greatest narrowing is in the perpendicular plate of the ethmoid and in the vomer, so in the bony septum. And that will remain that way until you do your septal rhinoplasty at the age of facial maturity and you take care of those things. So when I do my rhinoplasty when they're older, not only do I address the cartilaginous septum, but I also go farther back. And if you look back there, you'll see that in a significant number of those cases, a great majority of them, there's usually a very big bony spur put in a perpendicular plate of the ethmoid posteriorly, and that should be also removed to improve nasal airflow.
Thank you. And another thing I was intending to ask you about setback. You know that I'm against the setback of premaxilla, and using NAN and good orthodontist that you said, you think that you can avoid setback?
Yes, absolutely. I still do premaxillary setback, infant premaxillary setback infrequently, but I still do it. And when I do it is when I have patients who come to me late, who are, let's say, 6 months of age. Their premaxilla is looking at the moon, and that's a situation that many of us don't like. I know in your case that you do a staged lip adhesion, and remember when we were in Argentina, we spoke about this. To me, it's fascinating because I think a lip adhesion in those cases, you can, obviously the risk, you really have to know what you're doing. I think it's what you're doing is a bit more thoughtful, I think, than the average lip adhesion. But I would say that there isn't good data to show. I think premaxillary setback, there's a lot of things to it. In infant premaxillary setback, there's a lot of details. How you do the osteotomy. I do a very posterior osteotomy, which I think will preserve facial growth. And then how do you fix that premaxillary segment? What some people do, if they've put in K-wires through the face, which is very damaging, we will do GPP. So I have a growing cohort of patients that I've done a premaxillary setback, infant premaxillary setback with bilateral GPP. People thought you're going to kill the segment. It doesn't. It's fine. It's absolutely fine. I can show many patients who've done that. But what I want to know is about facial growth, and that's going to take time. But so that's how I do my premaxillary setback as an infant. But it's because most of our patients see us at an early standpoint, and we're using molding. We don't have that need.
Okay. Roberto, because I have personally more than 300 bilateral cleft that I follow, and actually I have less than 10 cases of performance setback around 8 to 10 years, not in a primary. But using NAN, you said that you don't need your 0% that you need to do setback, yeah. It's a great number. I think we can using these we can avoid the setback. But I think that the lip adhesion can also avoid the setback because it's not forced. You don't put the power to the premaxilla to be very like using some strong surgery that bring the for backward the premaxilla. And the last thing that I'd like to ask you, it's about the number of orthognathic surgery using GPP, and you said it's 38% your patient have unilateral cleft lip orthognathic surgery. Do you think this is a great number? Because I was expecting less than these, but 38 for me, it's too much. What do you think about this number?
Yeah, it's interesting. I've heard this observation, from many people. And so if you look at our, I would say a couple things. Number one, if you look at a rate for orthognathic surgery on patients with unilateral cleft lip and Vo3 cleft palate, and you compare that to the other leading units, ours falls in the average. It's not high, it's not low. That's in what's published. Okay. I've had people say that, oh my gosh, that's too high, that's too high. It's like, okay, then publish results. But for us, if you look at the cohort of patients who are followed to facial maturity, see for Vo3 cleft palate with complete unilateral cleft lip, that ours is within the average. But I think more important than because I think the indication for orthognathic surgery, some people more conservative, some people more aggressive, what have you. For us, the most important was facial growth parameters, right? That is where we're quantifying things. And that's why that part for us is the more important. And having the Eurocleft Center, which is really the highest repository. I know Eurocleft isn't perfect. That's been pointed out to me that people I respect. But at the end of the day, it's the best data that exists now. And we want to be data driven. We want to be numbers driven. And this is and we chose the best information that we could find to compare facial growth parameters. So, but I know people have said that, and I agree that there's variance. But what we want to know is, are we preserving facial growth? Are we doing detrimental things to facial growth? And the way we looked at it, we try to do this in the most transparent and science-driven way possible. This number is saying no.
Okay. Thank you, Roberto. Thank you, PY2. It's a great pleasure to be here today. And I did the 3 questions because I asked this, and I will give you back. Thank you.
Great to see you, Renato.
Great too.
Thank you so much, Professor Freitas. And next, I'd like to invite Dr. Tinchen Liu for some comments. Dr. Liu.
Hi, Professor Flores. So, thanks for your excellent speech and wonderful result. I do molar incision also, and I did a small triangular flap above the white skin roll if I cannot label the cubis bowl. I found in Asian patients, sometimes it's difficult to label the cubis bowl if you only use the molar incision. So how do you think, how much, like how many meter you can label with the molar incision, or you can do every case with the molar incision only?
So I do think that in Asian patients, as a general, I think it's going to be a little harder to implement this type of technique. And I think the reason is because the scarring can be a bit more robust in Asians, people of Southern Asian and even African populations. There are times where you can really get some robust scarring. So I agree. So I think that the limitation in that case is because you have that straight line, and then you have the contraction, and by breaking up the straight line with a triangle, you can do that. And I, and I've seen that. I've seen that in all my patients to a degree. It's a minority of them, but I do see that. One of the things that I've done over time is the apex of the molar back cut. You can actually go fairly high. When I would have people mark my students, they would do this very low, and you can go really, as long as you're within the columella, you can go as high as you want. All right, because if that vertical scar is very difficult to see. So at this point, I go 2 millimeters, which doesn't seem like a very high, a very long distance, but in an infant, on a 3-month-old, that can go up halfway up or more than halfway up the entirety of the columella. And what I do is when I do my back cut and I bring it down, the back cut is so relatively big. It's not big, obviously, that even when I bring it down, that let's say I have the back cut here, I will have excess skin at the top, and sometimes I have to trim that at the end. The other thing that I'll do is I will overcorrect at the skin level. I think many of us dissect the skin from the medial lip element a little bit, like a 1 millimeter, to lift the skin off of the muscle. And when I bring this, when I try to align the white roll segments, I'll actually bring the medial lip element just slightly lower to the white roll point on the lateral lip element, not in an exaggerated fashion, but I will say it's not 100%. Like I don't, none of us have perfect results. We like to show our better results, but those are the ways I've been evolving for that same observation. And I might feel differently I have a significant age. I have a very international practice. New York is an international city. We have people also coming in to see us from other areas. So, but I don't have a 99% Asian practice. So maybe my opinions would be formed a little differently if I was, faculty working, alongside you.
Okay, that's a very good suggestions. Thank you very much.
Thank you, Dr. Liu. Next, I'd like to invite Professor Fayez. Professor Fayez, you're still currently on mute.
Thank you very much, Roberto. Very excellent lecture. I literally feeling myself student again, and I learned some tips and tricks today from you. So I would like to know, do you use post-op nasal stenting to maintain the elevated nostril at a good level?
Very good question, and I did not mention it. And I know this is something that's advocated by many, and Chang has done some very good studies on this. The answer is I do not put in nasal stents immediately after surgery. I do that for a couple of reasons, and one of them is a surgical discipline. I want the nose to stand up on its own in an overcorrected position, and if I don't achieve that, I will get upset at myself and have to do it over. So you saw these pictures where the child is overcorrected, where they have, on the cleft side is overcorrected. I need to see that at the end of the day. And I actually send pictures to my orthodontist almost as a way to keep, it's like reporting to mommy, right? This is, this is my work. And what we do in our protocol actually is at 3 weeks after surgery, if we feel that the patient needs to have a stent, then we will implement it in there. But what I want is the nose should stay up on its own. When you do an adult rhinoplasty, you're not putting in nasal stents, right? You are reforming the lower lateral cartilage in its appropriate position so it holds the nose in place. And I feel that the same principles should be applied in the way I like to do rhinoplasty to infants. So it should stand up on its own. If afterwards you need it, and I would say at this point, maybe 30 to 40% of our patients are indicated for nasal stenting. And just to be clear, this is for people who were not in that perfect position, not people who've collapsed all the way down, right? I do think that the stent could be helpful, but the real work is in the overcorrection of the position of the lower lateral cartilages.
Okay, thank you very much. What we lately have been doing is when we do the surgery after 2 to 3 weeks, if the patient has cleft palate as well, when we do we do the obturator with the nasal stent. So we ask the family to keep the palatal obturator with the nasal stent on for at least uh, 4 to 6 months, so that the nasal elevation is maintained. So my next question is, because it's still a controversial whether we should do GPP during the primarily prepare or we should do GPP at 8 to 9 years of age. So do you do GPP at 8 to 9 years of age in some of your patients, or you always do at the primarily prepare time?
I don't do GPP at the time of cleft palate repair at 9 months of age or a year of age. I don't feel like I am doing the kind of job I want to do. One thing I do want to do is visit other units that are doing that or showing great success as they do in Milan, because I think I'd learned something. But I don't think from a technical standpoint I figured it out. I don't feel like I've done the kind of job I want to do, and I think this is a very technical procedure. I think it's easy not to do a good job, and it's easy to do damage. I think it's a technical procedure. So I'd want to learn from others that know more than me to really implement that on a patient with a cleft palate, well, during cleft palate repair.
Okay, so what I would make a suggestion to all the friends at the forum is that maybe we can develop a multi-centric, multi-continental research protocol about GPP, and we can follow our patient maybe up to 10 years or 12 years of age. So maybe we can come up with a very solid data to support or not to support GPP. So what do you think of?
I'm happy to share data. That's what we've always been doing.
Okay, thank you very much, Roberto. So very nice lecture, and see you in Milan.
Great to see you, my friend.
Oh, thank you.
Thank you so much, Professor Fayaz. And last but not least, I'd like to invite Professor Lowe.
Hi, Dr. Flores. It's nice to hear your presentation. Very nice result, and I would like to congratulate you your result. I think when I hear the discussion by these panelists, I think the two important issue. One is primary rhinoplasty, the other is GPP. And even right now in some Asian country or many Asian countries, still surgeons do not do primary rhinoplasty, and they do intermediate rhinoplasty in the preschool age. So I hope that today's presentation and discussion can bring some encouragement that more and more Asian surgeons can start to do primary rhinoplasty. And I also noticed that different surgeon, even you do primary rhinoplasty, different surgeon can have different method. Certainly, many of the intermediate rhinoplasty can be avoided when you do primary rhinoplasty. And with time, I think surgeon can be more and more experienced what procedure in primary rhinoplasty can achieve a better result. I think that's very important. Dr. Flores, can you talk about your experience when you do the primary rhinoplasty from beginning your practice and until today?
Thank you. That's a very good question, and I would second your kind of support. I mean, I believe that if you do primary rhinoplasty carefully, and carefully is important. It's important detail. You will have a better benefit to the patient. So the pictures of the children I've operated on, they're 10 years old, 8, 10 years old, and they can run around like all the other kids in the playground. I would say what I've changed over time is two things. One is that previously I would just say, oh, I have NAM, I'm going to do my rhinoplasty this way, or I don't have NAM, I'm going to do rhinoplasty another way. And in fact, surgical outcomes, just like orthodontic outcomes, are different, even in expert hands. And what I do now is I just clear my mind and just look at this kid's nose and say, what does this child need? And I think that seems like not a big deal, but it's actually a very big deal, because when you assume things, you stop seeing. And I don't, for me, it doesn't matter if they've had any kind of molding or not. I look very critically at what I need to do. And the other thing is I've done more to overcorrect the nose. I feel like that in my earlier work, we all have that relapse, right? This kind of it comes down, the lower lateral cartilage comes down. Maybe it's a nostril apex. And I've been a lot more mindful of the overcorrection and the diligence to proper position of the lower lateral cartilage. I think that part I've really been and I've built on many of the techniques that was passed on to me by Dr. Cutting, because I in looking back, there's still that collapse that is we'd rather not see, that we're all very familiar with.
Okay, the second issue is the GPP, and I remember many years ago when I first hear the result from Dr. Cutting and Barry Grayson, we in Chang'an also start to practice GPP. And then later I gave up because I don't think I have good enough technique to do GPP. Many of my patients actually have growth restriction from the GPP procedure. But tonight I hear your result, I really maybe GPP may not be a big procedure. And you mentioned that orthodontic is important, surgical technique also is important. Now, these may not be available in many other centers, In Chang'an, we do have very good orthodontic support, but in terms of the GPP surgical technique, maybe someday I need to observe your operation so that I see really what I can learn from your GPP technique. Will you comment on this?
Oh, I would love to have you come to New York, and we have visitors very frequently. But you've touched upon something that one of my mentees, who's now at Johns Hopkins, pointed out to me, and he said, you need to create a video because your unit is one of the few that are actually doing this at a high volume at this point. And unless you show technically what you're doing, you're doing yourself a disservice. And I don't know why, but it didn't register that I should do this. But that's something that we're probably going to work on this summer. I think doing a video on an infant alveolar segment is actually a lot more difficult. A good quality video is a lot more difficult than it seems. You're showing even more detail than you would on a nose or a lip repair, because it's a small segment. It's about 3 millimeters. So I think that we have to think about how we're going to work the camera with this, and I don't like the head camera and everyone gets dizzy. So we would like to do that, but certainly Dr. Lowe, I'd love to have you as my guest in New York to come in.
Well, just firstly try to make video for everyone.
Yeah, no, we'll do that. We can make that available. Of course, we want to publish it with the technical aspects of it, but
Yes.
but I think that's something that's on our lists. That's on the list.
Yeah, that's very important. Thank you very much. Yeah.
Thank you.
Thank you, Professor Lowe. And thank you, Professor Flores, and all the panelists once again for the in-depth discussions during this panel discussion. Now, next on our agenda is supposed to be the Q&A session, but due to the time restraint, I think we'll skip the Q&A session today, but instead we'll collect all the questions and then send them to Professor Flores and then ask him to answer it for us, and then we'll post the answers on for the questions on our Facebook group. Would that be okay, Professor?
Happy to help.
Okay, that'd be great. And Yun, would you like the honors
Yes.
of taking over?
Yes, thank you. Thank you, Professor Roberto Flores, for your wonderful and very comprehensive lecture. I think the time is not enough to learn more with you, especially for the bilateral cleft. Yeah, you just give me a very little the notice about that. But hopefully we will meet in Milan for more talk and more discussion. I believe that Maria now is online with us also. And most of our participants will meet over there in person. And I would like to thank you, Professor Raymond and Professor Renato Freitas. Thank you, Raymond, for your early getting up and a very early morning. Thank you for your coming. And thank you, Professor Renato. You let me know your house is so big. Yeah, quite a lot. Hopefully to visit you in the future. Always, I would like to invite all our participants to come and show yourself. Please turn on your screen. We would like to have a group photo. Before the group photoing, I have to advertise again about the following two, the series of the pre-congress of the Chang Forum 2024. 2 weeks later, our presenter is the Professor Jordan Swanson, and he will focus on the mastery advancement for those patients with cleft. And 1 month later is the Professor Percy Russell, and he will present the primary cleft rhinoplasty too. Yes, so welcome for all our participants come join for this presentation. All right, thank you for my friend, and I hope you can give us a big smile. And I will count to 3. Thank you for your coming. 1, 2, cheese. Thank you very much. Good morning and good evening. See you in Milan, and 2 weeks later, we see you in online with us too. Bye-bye. Thank you for your coming.
Bye.
Thank you very much. Thank you, Robert. Thank you, Raymond. Thank you, Professor Renato. Thank you, EK. And thank you, Fukui. Thank you, Professor Nevado Alonso. Thank you, Kamis. 谢谢 Professor Low. Thank you, Tin Chen. Have a good night. Bye-bye. Thank you, Junior.
Good night. Good night.